And today I'm here to talk about the late effects guidance, and that's because basically I get referrals from all over the world now of patients saying, no one told me about these effects, no one knows what to do with them, I just keep being told, oh, that'll be the radiotherapy, and they're living for decades like this. Also, patients get to the point where they're not under follow-up sometimes anymore, so then they come up with a symptom or a side effect that is to do with that radiotherapy. Well, who's responsible then for managing that? So myself and this fabulous Sabina Khan, who's another consultant radiographer from down at UCLH, got together and we said we need to have some form of guidance for health professionals so that they know what to do if they have a patient under their care. So this can be GPs in primary practice, it can be anybody in the hospital setting, but also for those specialist teams, because even though, like Christine was saying earlier, her specialist didn't know about salivary gland cancer. Well, believe it or not, there's many surgeons that don't know about radiotherapy late effects either. So it's really important that we get this message out there, and we started with the guidance of, it says, if I can move this forward, there we go. Okay, so we know that patients are living so much longer, and that's fantastic, but these long-term side effects are really common. I see about 700 new patients a year in our practice, and around 300 to 400 of them tend to be head and neck patients. The problem we have is that many are unrecognised and often ignored and also unreported. And that's also because they vary in severity. It may be a slight dry mouth, but for some patients that dry mouth can be really significant, to be in a little bit of pain, to be in excruciating pain, and I'm not going to work anymore. I don't really feel like I'm living my life. The issue we have is a massive variation in follow-up, and I do not need to speak to this group about that. But we know that a lot of cancer types now, the initiative is going to actually the patients to follow-up. So it's called patient-initiated follow-up, and that's where you kind of taught to feel your neck yourself, and you just come back in. You've got rapid access back in. So they're not having these questions always asked. They're not always seeing the rest of the multidisciplinary team. So the speech and language therapists, the dietitians, the physios, the lymphedema specialists, and these are often the health professionals who pick up these late effects. So we know also that late effects are often missed. And this is quite tricky because sometimes we have to determine whether do we think this is a cancer recurrence, is it something to do with another long-term comorbidity that a patient's got, or is it a late effect to that treatment? So we really need to educate health professionals and patients about what the late effects are, so that you can at least put that in that bracket for diagnosis. We need to be much more proactive rather than being completely reactive, and that's how I've always been. You go for follow-up or you get referred back in because you've got this. Well, there are things that we can do to try and prevent the severity of these late effects, and well, some of the research that I'm going to be doing is actually, I believe we can start to really stop some of these late effects occurring in the first place. And we know that patients fall through gaps. So, you know, I see some patients, they come into my service because I screen all our patients for 10 years, all the head and neck patients, trying to really try and proactively look for these late effects. And sometimes these patients come and they've not had follow-up for 2 years. And I'm like, well, why have you not had a follow-up? Well, they didn't send me an appointment. And this patient don't think to ask because they don't like to bother. So what we know is, from patients' experiences, that in terms of head and neck patients, 50% will have unmet needs beyond 5 years. We know that 85% who have radiotherapy will have swallowing difficulties, with up to 90% having lymphedema, so that's when you get a collection of the fluid in the tissues. But this is not only external, it's internal lymphedema as well, and that's what often affects the swallowing function. And we know that 34% are going to get this, what we call severe fibrosis. So what is a late effect then? So a late effect is one of the side effects that you may get during your radiotherapy that never settles, or something that can then develop because of the radiotherapy, and we class a late effect as anything from 6 months post-treatment. The problem we have with radiotherapy is they may start many months, years, even decades after treatment. So certainly some of our longest patients out of treatment, they're both head and neck patients. One is 42 years and one is 49 years. The patients who's 49 years out of treatment has been struggling for 30 years with those late effects and have never found any support until they moved to Nottingham and got into our clinic. So the next thing we also have is about the process, yes, and we've got to, they vary from patient to patient as to whether they are going to be just niddlesome, or whether they are affecting your real quality of life and your function, and that's why it's really, really key. So in terms of radiation fibrosis then, this is why radiotherapy is called the gift or the treatment that keeps on giving. It's fantastic at getting rid of that cancer in the first place, eliminating that cancer, but it also causes damage to normal tissue. And really what happens is when your healing process becomes abnormal and you get this build-up of this thick fibrotic scar tissue, which leads to stiffness and then to the reduction of the function of that part of the body. So in terms of the head and neck, we have everything going on there, don't we? That's how we eat, that's how we communicate, and that's why it has such an impact on patients. I think everybody today is head and neck, aren't they? So I won't cover any of the other late effects from salivary gland, but we do see patients who've had salivary gland in other areas as well. So what happens is essentially the healing process becomes unstuck and goes into this overdrive, and you get an ongoing cellular dysfunction. So it's not just about like surgical scar tissue is quite linear. It's this progressiveness of this extra laying down of collagen and fibrin, and the whole area just becomes like a depleted landscape, really. We know it's this self-percepting cycle, and that's what my treatments are doing. They seem to be stopping this cycle and reversing that fibrosis, and that's the red light therapy that Emma talked about earlier. And we also know that if we do not start to put some interventions in place, so whether that's even basic exercises, your fibrosis will probably get worse. So how does it affect you then? Well, the first thing that most patients would comment on is this dry mouth. Then we start to think about the swallowing difficulties. That may be because of this dry mouth and the fact that you can't get your food into a bolus to move it to the back of your mouth to swallow, but it can be that we actually start to stiffen your swallowing apparatus as well. So often patients will talk to me about they feel like they're getting this feeling of tightness, they can't open their mouths as much anymore, and they can feel like their heads or whatever part of the body is in like a vice, is how they'll explain it. And then we start to develop pain as the fibrosis starts to affect their nerves as well. Obviously we see speech changes. Remember, if you've had surgery as well, it's only going to compound those effects that you've had from the surgery. And also you must never underestimate the emotional impact, so the psychological and psychosocial effects of these side effects that we're leaving patients with. So I said earlier we wanted to make some guidelines. So what was really important for us that we had a fully MD approach, but also getting those professionals into the MDT for this who are not necessarily on the main MDT that we see in our head and neck clinics. We wanted to involve the psychologist, the gastrointestinal team, the bone teams, absolutely everybody that we sometimes send patients to for these rarities. So basically we got together and we said, right, we want to do everything from the very bare minimum that a patient can do, such as for a dry mouth using oil and water, to what we can absolutely do in terms of gene and stem cell therapy for that dry mouth. We wanted that array of guidance. We also wasn't that bothered about it being evidence-based, because it's what patients are using and what clinicians are using in clinical practice. We have got evidence-based stuff in there as well, but that's really important because it's about what's out there and what's available. So this is the lovely imagery provided by Salivary Gland Cancer UK, I might add. So we got together and we put these guidance together, and it's just now going out for endorsement. So why does it matter? Well, one, we want standardised care. I want to be able to, if a patient contacts me or a clinician, I want to say, here you go, there's some guidelines. Yes, I will help, but actually some guidelines, you'll probably find the answer in there. But we want to standardise that. We want to improve recognition early so that patients are not living for months, years, decades with these side effects and not knowing what they are. And we want to support clinicians, especially those clinicians that have got no access to these late effects services, because only 29 of us, not many see head and neck patients, it's mainly pelvis patients. How can we support clinicians, clinical nurse specialists, GPs who may be seeing these patients? And obviously we want to improve outcomes. So before we had any guidelines, we're finding that it's reactive care, it's inconsistent. A patient will come to me and say, well, they've tried this, they've tried that, they've done biopsies here, there and everywhere, and actually sometimes made the problems worse. So we want to have this structured, proactive pathway, and essentially want to stop missing these symptoms and provide this early identification and support to all patients who've had head and neck radiotherapy. So what I want from you now is our second phase of this is to create a patient guide. We want a guide for you that you can then go to your GP in the first instance if you haven't got a specialist, because remember, some cancer patients are not under follow-up anymore. So what would you want from a document, a booklet? What would that be? An app that you could put your symptoms in? Maybe what would come up with that for information? What would that look like? We want to put something in there about self-supported management, so lots of tips and things, because we know patients search the internet for how to manage their dry mouth. Is there one place we can have for all this information that's there? And we really want to aid and improve those conversations that you're having with your healthcare professionals. So my question today is I'd like you to have a little chat on your tables, and online you can put things in the chat, or we can just shout out whatever we want to do. Is there anything surprised you after you've had your radiotherapy? Many patients have had radiotherapy today. What surprised you? Has there been anything that's missing? Were you educated about late effects? What do you wish you'd known earlier? And in this guidance, we want to get it right. We will have patient involvement, obviously, when we get around to doing it, but just so we can take you back and start thinking about this now, what format do you think would help? Okay.